In this lecture, we're covering all things eating disorders for the NCLEX. Let's start off with the two major eating disorders that you need to know. We have anorexia and bulimia. Now, both involve severely disordered eating patterns, but here's the key difference. Anorexia is all about extreme calorie restriction, which causes dangerously low body weight. Bulimia involves cycles of binge eating and purging. Now, the important distinction that's likely to show up on the NCLEX is that clients with bulimia usually maintain a normal body weight, so at first glance, they might not appear that sick. Let's take a closer side-by-side look at how anorexia and bulimia present. On the anorexia side, the severely restricted calorie and fluid intake means that the body simply doesn't have enough fuel, so it goes into power-saving mode. Now, the body runs out of fat stores, so it starts breaking down muscle tissue for fuel, which leads to cardiac atrophy, causing low heart rate and low blood pressure. Restriction of food and fluids causes dehydration and electrolyte imbalances like hypokalemia, which is dangerous because it can cause cardiac dysrhythmias. And remember, the body is in low power or energy saving mode. So we also see things like poor concentration because the brain just isn't getting enough fuel. We're going to see low energy as the body tries to avoid any activity that would burn extra calories. And we see amenorrhea, a classic sign that the body is shutting down non-essential systems in order to conserve energy. Now, on the bulimia side, clients, remember, usually maintain a normal body weight. So the findings come from the binge purge cycle. And key findings here are going to include dental erosion from repeated vomiting and stomach acid damaging the enamel. We'll see scars or calluses on the hands. This is called the Russell sign from clients using their fingers to self-induced vomiting. And just like anorexia, dehydration and hypokalemia are common because repeated vomiting and laxative or diuretic abuse deplete fluid and electrolytes. So let's talk more specifically about anorexia. Now, this disorder is driven by an intense fear of weight gain. Therefore, clients engage in extreme calorie restriction, leading to dangerously low body weight, which impacts pretty much every system in the body. So let's take a closer look at what we can expect to see when we're assessing these clients. So when caloric restriction is extreme and prolonged, the body enters a state of starvation. And when this happens, the body starts shutting down non-essential functions to conserve energy for survival. So you can think of this as your cell phone going into low battery or power saver mode. Now for the body, this means that the heart rate, blood pressure, and temperature all drop as the body tries to conserve energy. Cognition slows down because the brain is running on really limited fuel. The digestive system becomes sluggish, leading to constipation. Thyroid function declines, causing hypothyroidism, and the reproductive system in females shuts down because the body sees this as a non-essential system for survival, which is why we see that classic finding of amenorrhea. Now, restriction of food and fluids leads to dehydration and electrolyte disturbances as well, and we especially worry about hypokalemia because of its ability to trigger dysrhythmias. And finally, the body tries to conserve heat by developing lanugo. That's that fine, soft hair on the face or the arms that the NCLEX loves to ask about. Now, we know that starvation decreases cognition because the brain's not getting enough fuel, but we can also see an increase in rigid and inflexible thinking. And that's why we see things like distorted body image, meaning that even dangerously thin clients believe that they are still overweight, and they will strongly deny that there is any problem with their eating or their weight. These clients will also hyperfixate on weight, count calories, engage in excessive exercise, and follow strict food rituals. All of this typically leads to depression, anxiety, and social withdrawal as the disorder progresses. And here's one more pattern to look for. Many clients with anorexia have a history of perfectionism and really high academic achievement. It's that drive for control and high performance that often plays into the development and maintenance of the eating disorder. Okay, now let's look more closely at bulimia. Now remember, unlike anorexia, where clients mostly focus on restricting calories, bulimia is defined by this binge purge cycle. Now, binging refers to eating an excessive amount in one sitting, often thousands of calories at once, while experiencing a total loss of control that they feel powerless to stop. Now, that binge is then followed by overwhelming feelings of guilt, shame, and fear of weight gain. So, to cope with those feelings, clients turn to purging behaviors, which include things like self-induced vomiting, laxative or diuretic abuse, or excessive exercise, in an attempt to purge these excess calories from the body and prevent weight gain. But of course, purging only brings about temporary relief and negative emotions like loneliness, stress, depression build up again and trigger another binge episode, and then the cycle keeps repeating and repeating. Now, when we're assessing clients with bulimia, remember, they typically have a normal weight, which is why it can be harder to recognize. So instead, we look for clues related to purging behaviors like vomiting or laxative or diuretic abuse. The most classic signs we see are dental erosion, which is caused by gastric acid from repeated vomiting, breaking down the enamel. We might also see swollen parotid or salivary glands, which occurs when repeated vomiting causes them to become inflamed and gives these clients a chipmunk cheek appearance. We might see scarring or calluses on the hands or the knuckles, known as the Russell sign, and this happens when clients use their fingers to repeatedly induce vomiting. Dehydration and electrolyte imbalances, like hypokalemia, are common here as well because vomiting and laxative or diuretic abuse causes major fluid and electrolyte losses. Now, psychologically, clients with bulimia often struggle with low self-esteem, guilt, and even disgust after episodes of binging, and they're usually very secretive about these behaviors and go to great lengths to hide their binging and purging behaviors from others. So on the NCLEX, if you have a normal weight client who also presents with dental erosion, swollen parotid glands, and calluses on the knuckles, you need to recognize this as bulimia. All right, it's time for our first NCLEX quick check. Take a minute to pause and see if you can answer. Okay, first up, both anorexia and bulimia increase risk for what? Hyperkalemia or hypokalemia? That is going to be hypokalemia because both excessive calorie restriction and purging behaviors can result in low potassium. Next, true or false? Clients with bulimia are typically underweight. We know that is false. Clients with bulimia are more often normal weight, unlike clients with anorexia, who typically present as severely underweight. And lastly, can you name 3 findings that indicate self-induced vomiting? In these cases, we're going to see things like dental erosion, swollen parotid glands, and scarring or calluses on the knuckles or hands. Now, when it comes to interventions, the NCLEX will focus on 3 main concepts, which are restoring body weight if needed, reducing complications, and encouraging behavioral change. First off, we need to start by restoring body weight if the client is underweight. Now, this is really important. The goal is gradual weight gain of about 2 pounds or 1 kilogram per week. Anything faster can trigger refeeding syndrome, which is life-threatening. To support this, we use consistent and structured meal times to ensure steady calorie intake. We supervise during meals to prevent clients from trying to hide or discard food, and we continue to supervise 1 to 2 hours after meals, including bathroom visits, to prevent any purging behaviors. It's also going to be important to encourage socialization during meals to normalize eating and distract from anxiety. Now, to conserve calories, we limit physical activity during treatment, and in severe cases, nasogastric or parenteral feedings may be needed. Now, if the NCLEX asks you how to evaluate progress, remember, we do this by weighing the client at the same time each morning, in the same clothes, after the client has used the bathroom, but before they've eaten breakfast. This will give us the most consistent measurements, and it's the most objective indicator we have to track treatment progress. But remember, we never force clients to view their weight because this can be really distressing and cause setbacks in treatment. Along with weight restoration, we need to prioritize reducing complications, and there are 3 major risks the NCLEX wants you to recognize. First is suicide risk. Clients with eating disorders have one of the highest suicide rates of any mental health condition. Severe depression, hopelessness, and poor coping skills, all worsened by the effects of malnutrition on the brain, make this a top priority. So we continually assess suicide risk and implement suicide precautions if indicated. The second major risk is electrolyte and cardiac complications. Disordered eating leads to electrolyte imbalances and cardiac atrophy, which increases the risk for dysrhythmias and even heart failure. So we monitor electrolyte levels really closely. We also report any ECG abnormalities to the healthcare provider, like severe bradycardia or prolonged QT interval. And we monitor orthostatic vital signs since dehydration and hypotension are really common in this population. And finally, we have refeeding syndrome. And this happens when a malnourished client gains weight back too quickly. Now, the hallmark sign is severe hypophosphatemia. So if you see this, it's definitely a priority finding that requires immediate provider notification, because if left untreated, refeeding syndrome can lead to respiratory failure, dangerous cardiac dysrhythmias, and even death. This is why gradual weight gain is so important. So remember, about 2 pounds or 1 kilogram per week no faster. So once our client is medically stable and we've done our best to prevent any complications, the focus shifts to encouraging behavioral change. First, we want to teach anxiety management skills that don't revolve around food or exercise. So things like journaling, meditation, or spending time with supportive family or friends are all really helpful strategies here. Second, we want to avoid focusing on the client's weight or appearance. Even if a client is severely malnourished, it's not therapeutic to say things like, "You're so thin, I can see your ribs." Instead, we want to focus on the client's strengths that aren't related to diet or appearance. For example, we might say things like, "Your artwork is beautiful," or "You're such a talented piano player." This helps rebuild an identity outside of food and weight. And finally, we want to encourage family involvement in treatment, especially for our adolescent clients, because family support and participation are critical for long-term recovery. All right, it's time for our last NCLEX quick check. Take a minute to pause and see if you can answer. Okay, first up, true or false? The nurse should allow the client privacy during and after meal times. This is false. Remember, clients should be supervised during meals and after to prevent hiding or discarding of food or purging behaviors. Next up, how much weight should a malnourished client gain per week? That is going to be about 2 pounds or 1 kilogram per week because rapid weight gain can trigger refeeding syndrome. And lastly, what is the hallmark finding associated with refeeding syndrome? That is going to be hypophosphatemia. If you see this, it's a priority finding. You need to notify the healthcare provider right away. All right, you're all set for eating disorders on the NCLEX.